All right. Good afternoon, everybody. Thank you so much for joining us. I am Jessica Steinke with the New York City STI HIV Prevention Training Center. Welcome to our webinar today on syphilis during pregnancy, taking place on the second annual New York State Syphilis During Pregnancy Awareness Day. Before we get started, I have a few housekeeping items and then I'll introduce our speakers. We are recording today's webinar. We do not consent to others recording this webinar or to using AI note-taking, so we ask that you refrain from doing that. For any questions you have throughout the webinar, please use the Q&A box located at the bottom of your Zoom screen. It might be under the More button. We ask that you use the Q&A box and not the chat because it's just easier for us to track the Q&A, and then we'll address questions at the end of the webinar. This webinar is accredited for CME and CNE. We'll send those instructions by email later this afternoon. All right, at this point, I'm going to introduce our speakers. We have two wonderful speakers today. Our first speaker is Dr. Preeti Pathela. She's the Executive Director of the STI program in the Bureau of Hepatitis, HIV, and STIs at the New York City Department of Health and Mental Hygiene. Dr. Pathela has overall responsibility for directing, evaluating, and coordinating the activities of the program, which consists of roughly 85 staff who conduct work in STI program implementation, surveillance, field operations, and epidemiology research and evaluation. She has 22 years of experience in the field of STI and HIV prevention and control, and she serves as president-elect of the American STD Association's Board of Directors and as an associate editor of the Journal of Sexually Transmitted Diseases. Our second speaker this afternoon will be Dr. Jason Zucker. Dr. Zucker is an assistant professor of medicine in the Division of Infectious Diseases at Columbia University Irving Medical Center, and he serves as the principal investigator and co-medical director of the New York City STI HIV Prevention Training Center. Dual trained in adult and pediatric infectious diseases, he provides status-neutral HIV prevention and sexual health care across the lifespan at the New York Presbyterian Columbia Comprehensive Health Program Sexual Health Clinic. So we're very excited to have both of them with us this afternoon. And Dr. Pathela, I'll turn it over to you to get us started.
Thanks so much, Jessica. Let me share my screen. Okay. That's projecting correctly?
Yes.
Okay. Hello, everyone. I'm really delighted to be here to provide an overview of congenital syphilis in New York City. And as Jessica mentioned, this is to commemorate the second annual Syphilis During Pregnancy Awareness Day. The first one was on August 25th, 2025. At that time, the governor had signed a proclamation, and landmarks and buildings across the state were illuminated in the colors magenta and white in a symbolic effort to raise awareness about congenital syphilis prevention. So this year's commemoration is happening tomorrow, formally, August 25th. And before I get into the focus of today's webinar, which is around congenital syphilis, I just wanted to zoom out for a minute and talk about syphilis in general and adult syphilis. This slide shows national data on rates of reported cases by year, going all the way back to 1941. And you can see here that in the 1940s, we had the highest rate on record for all stages of syphilis, approaching 450 per 100,000 population. And then the advent of penicillin and other control efforts really helped drive this rate down. We had a blip in the late 80s, early 90s associated with the crack cocaine epidemic and the exchange of sex for drugs or for money to buy drugs. Again, aggressive control efforts, including those in correctional facilities, helped to bring that rate down until the late 90s, 2000, when we started to see the sustained uptick. And so what are those rising rates all about? There are many contributing factors, many having to do with advances in HIV, both in terms of treatment, so that people with HIV were living longer and resuming sexual activity after many years of not being able to do so. We had the arrival of prevention modalities like pre-exposure prophylaxis for HIV and the concept of undetectable equals untransmittable, which are all great for HIV prevention. not for STI prevention. And that because syphilis just really wasn't on the radar for many providers, there was a lower level of knowledge about symptoms and appropriate screening and treatment. And at the population, lower condom use levels over time, the increasing use of dating apps and hookup apps to find sexual partners, and of anonymous partners, which makes contact tracing and partner notification very difficult, if not impossible. And then we've had population level increases in drug use, illicit drug use, and structural vulnerabilities, including housing instability and declining mental health status, all of which are associated with increases in STI. So now focusing just on New York City data, I'm going to show you a number of different slides showing the epidemiology of syphilis here going back 25 years. This is for primary and secondary syphilis case rates stratified by reported sex. So this for us mainly reflects the reported sex at birth of cases and not necessarily gender identity. You can see here that male and female cases case rates in 2000 were virtually identical, and then the rate among men really took off, and which what drove the overall rising rate in the city until 2022. And since then, we've seen this really precipitous decline, which is great news, and thought largely to be in part due to the increasing use of doxycycline as pre-exposure prophylaxis for STI prevention, also known as doxypep. There's a bit of a spillover effect in addition to many other intensive control efforts around syphilis among women, which has also brought down that female rate a little bit, but you can see that it did start to rise in 2016, alongside the male rate also increasing across all of that time period. And here we have early latent syphilis case rates, similar data showing that steep rise among men from 2011 for about 11 years, and then again, large drop starting in 2022. And here we have the late or unknown duration syphilis case rate stratified by sex, really more of a steady state here, although some of the same patterns that we saw for the earlier stages of syphilis. So now I have these data for 2023 versus 2024. I'll just say that our 2025 data are currently being collated for publication in our annual surveillance report, which is expected to come out this fall. So apologies that I'm just showing data through 2024. I'll give you a little spoiler that for 2025 and for the first half of 2026, we've seen even better and better news with drops in not only syphilis, but also in gonorrhea and further drops in chlamydia as well. So that all is very promising. However, I do want to say that despite that good news, we have these persistent inequities that we are always very concerned with. So we have differences by race and ethnicity. This shows for primary and secondary syphilis case rates, the fact that for New Yorkers who identify as Black or African American, they really carry a disproportionate burden of syphilis. Second to that are people who identify as Hispanic or Latino, and you can see that the case rates for those two groups converged in 2024 at about 25 per 100,000. We also have disparities when it comes to geographic area. This is based on the reported residents of cases who we know to be diagnosed with primary and secondary syphilis, yes, and then the right map is for early latent syphilis. The darker shades of these maps depict neighborhoods where there are higher or the highest case rates. And so you can see here for both really all stages that are shown here, that we have hotspots in Lower Manhattan, in Central Brooklyn, in the area of Queens that neighbors Manhattan, and then Upper Manhattan and South Bronx as well. Focusing now on congenital syphilis. So here we have our CS case numbers, 2010 through 2024. For many of the years, all the way up till 2018, we had between 5 and 10 cases per year, and this is citywide. So although every case represents a call to action, it wasn't as alarming as what was to come, except for 2014 when we did have a blip 120 reported cases that year. Really, since 2018, we've had 20 or more cases, or approaching 20 or more cases every single year, including several cases where there have been stillbirths or infants who have died after birth, really representing the most tragic stages of this condition. And this is juxtaposed with the case rate per 100,000 feet secondary syphilis. So not surprisingly, as that case rate has risen, so has the number of congenital syphilis cases, with the exception of these last couple of years where, again, luckily, we're seeing a decline in the female case rate, and in 23 and 24, not a concomitant decline in the number of CS cases, although we are starting to see that for 2025 and 2026. Looking now at the syphilis stage at diagnosis among birthing parents of the congenital syphilis cases over these 6, 7 years, you can see that early on in this time period, most cases were born to CS cases were born to people who had syphilis that was early non-primary, non-secondary, so these later stages of disease. And then further on, we're getting into even later stages of disease with later unknown syphilis being the primary diagnosis or the predominant diagnosis for these both birthing parents, really pointing to the importance, the critical importance of routine screening to pick up these asymptomatic infections. Looking now at congenital cases by borough of residence at the time of delivery, there's been some shifts here too. Early on in this time frame, we had many cases that were reported from the outer boroughs of the Bronx and Brooklyn, and kind of more recently in 2024, a little bit more of an equal distribution and an increasing proportion of cases reported from Manhattan. Looking now at the race ethnicity of birthing parents, you can see here declines in most of these groups, with the exception of birthing parents who identify as Hispanic or Latina, where we've seen an increasing proportion, now at 60% of all cases in 2024. The average age at delivery among birthing parents of CS cases has remained quite consistent at about 27 years. And the place of birth among birthing parents, this is where we've also seen some changes with a higher proportion of cases being born to parents who are not US born. The housing status, also differing trends here compared to the earlier years, where about 30% in 2024 of birthing parents reported being unhoused or residing in shelters. And the final data point I have here among birthing parents of CS cases is around prenatal care. So we can see here for 23 and 24, about 50% of these parents have evidence of late or but that really leaves a sizable proportion who actually have been engaged in prenatal care and have had prenatal care for the durations of their pregnancies. But where we're seeing those missed opportunities are around screening at appropriate intervals and appropriate treatment if syphilis is diagnosed. And this is a reminder for me to say that there has been mandated third trimester screening for all pregnant individuals in New York City since November of 2019. This also became a state mandate in 2024 and has been in addition to the pre-existing state laws to screen for syphilis at the first prenatal visit and also at the time of delivery. So appropriate screening and treatment has been, as you can see, those have been challenges. Another kind of more recent, but at this point, longstanding challenge as well has been around treatment and the availability of long-acting penicillin. So long-acting benzathine penicillin G by injection has historically been the only domestically available product composed purely of BPG. Bicillin is the recommended treatment. It's the only treatment, notably, for pregnant people and for infants with congenital syphilis. And we've had a shortage in this country that was announced by the FDA in April of 2023. This shortage was exacerbated by a recall of specific bicillin lots last year around this time Pfizer has recently extended the recovery timeline to the fourth quarter of 2027. And I don't think any of us would be surprised if we find out that there will be a further extension on this. So, in terms of treatment during the shortage, the Centers for Disease Control and Prevention and numerous jurisdictions have advised treating non-pregnant people or patients with doxycycline to preserve this inadequate supply of bicillin. On March 6th of this year, the FDA announced that it would allow the temporary importation of lenticillin to address ongoing bicillin shortages. So we have been very busy at the health department with a number of different provider communications. I hope that everyone on this call subscribes to the agency's Health Alert Network, or HAN, which provides medical providers with up-to-date information and calls to action. This is where you can find health advisories that get put out by the agency. We also have Dear Colleague letters that go out using different avenues that outline screening and treatment guidelines. Our most recent in this area of congenital syphilis and syphilis more broadly came out earlier this year, looking at or really providing guidance on treatment options given our benzathine penicillin G injectable shortage. And this is what that health advisory looked like, with a number of different recommendations, including that BPG should be prioritized for populations for whom it is the only recommended treatment. Again, these are pregnant patients with primary, secondary, or latent syphilis or exposure to syphilis, infants who may have congenital syphilis due to in utero exposure, who meet selected criteria, and people with syphilis or exposure to syphilis who are unable to take doxycycline. We say to treat non-pregnant adults with doxycycline, not to use macrolide antibiotics such as azithromycin and erythromycin. They're not effective in the treatment of syphilis due to antibiotic resistance. We guide providers to refer pregnant patients and patients for whom doxycycline is contraindicated to our health department sexual health clinics. Information on their locations and hours are available on our health department website. And this is for treatment if BPG is unavailable, and to consider lenticillin for treatment, and then to contact us if any of your sites are experiencing a shortage by emailing the address that you see on the slide with the name of your facility and notifying us that it's about the bicillin shortage. We can advise on other facilities that have adequate supplies. We have a newly released provider toolkit. This provides clinical tools and resources to support healthcare providers across a number of clinical settings. These materials and additional supporting information can be downloaded at our website. There are a number of different PDFs sectioned off into these various areas that are included in the toolkit. And we have been monitoring the bicillin supply and treatment by regularly querying high syphilis reporting healthcare facilities across the city about their bicillin shortages and their efforts around conservation. This active outreach provides us with timely, actionable insight that our otherwise passive surveillance would miss. And what we found is that consistent messaging on the conservation is needed until the shortage is resolved. We're using our surveillance data to monitor bicillin supply and treatment. This is to track treatment with non-recommended regimens citywide. And this graph here shows what's been going on for the first 4 years and change, where in the most current quarter of 2026, you can see that 72% of the non-bicillin treatment that was given to reported syphilis cases was because bicillin was unavailable, and the facilities are doing this to conserve supplies. And then finally, I'll talk about the Congenital Syphilis Elimination Strategic Planning Group. So this group was convened by our New York State colleagues, and several of us at the New York City Health Department also got involved in this community-led strategic planning process to develop a statewide elimination framework that followed a 410% increase in congenital syphilis cases that we saw statewide between the years of 2012 and 2022. And this included a steering committee and 43 representatives from public health, healthcare, community organizations, and academia that were organized into subcommittees to undertake health equity focused and trauma informed work. The group met over 13 months to identify actionable strategies, and the results of which were a compilation of six prioritized and 18 general recommendations for implementation. And for anyone who's interested in knowing more about the process of putting together a plan like this, there is a publication that came out in Public Health Management Practice just last month. So this congenital syphilis elimination framework that resulted from that 13 months of effort came out in 2024. This was the first ever congenital syphilis elimination framework for the country. In 2026, just a few months ago, there was a release of an updated version of the framework. The recommendations, which you can see the six prioritized ones on the right of the slide, they remain unchanged from when this work was done. But the enhanced content in this new release highlights the role of social determinants of health in congenital syphilis transmission, and also establishes, and also something that we're doing in 26 is to establish metrics to define targets and track progress towards sustainable CS elimination in the state after implementing aspects of this framework. So I mentioned the priority recommendations here. They're really focused on expanding access and testing opportunities in both traditional and non-traditional healthcare settings, educating and increasing awareness among patients, partners, and the public, improving and ensuring provider education and accountability, strengthening public health and partner collaboration, increasing and supporting data sharing and surveillance, and creating systems to support immediate response. And with that, I will end. Just take a second to acknowledge a number of colleagues in my program who are so integral to this work, and not only those who are listed here and the units that are listed here, but really to my entire program. All of our work really touches on this crucial issue. And so with that, I'll turn it over to Dr. Zucker.
Thank you so much for that. And again, you guys do amazing work, and thanks to everybody at the program there. I'm now going to take it on and talk about some of the clinical aspects about syphilis during this awareness time. Hopefully, you guys see my screen correctly. I apologize. Hopefully, you can hear me okay. I'm losing my voice a bit. So, one of the things I think are really important is to understand why congenital syphilis cases were rising. Luckily enough, here in New York City, we're making progress, but across the country, we're still continuing to see cases rise. And it's because of a couple of things. About 37% have no timely test, 40% have inadequate treatment, 11% have no treatment, and 12% are for other reasons. But that really means that for 88% of the cases, we have really clear cases where we can intervene. We can do more testing, we can ensure people get adequate treatment, and that's what we're going to cover today. We care about this because transmission of syphilis can actually begin as early as 9 to 10 weeks, and it can occur at any stage of maternal disease. Fetal abnormalities won't be seen before 18 to 20 weeks because that's when the fetal immune response is mature. So normal ultrasound doesn't necessarily exclude infection, but the risk window opens earlier than most people expect. Again, this shows that fetal risk is at any stage of maternal disease, and that we recommend in New York City and New York State testing 3 times during the course of pregnancy. The second reason that we care is that because there are very negative outcomes associated with this. In fact, 2/3 of untreated pregnancies ended in adverse outcome in people with syphilis. This was a really interesting systemic review that I was reviewing earlier this week. 66.5% of patients with untreated maternal syphilis have adverse outcomes like congenital infection, miscarriage, stillbirth, preterm birth, impaired growth, and neonatal death. And that's compared to 14% of those without syphilis. So obviously much higher in those with untreated maternal syphilis. There are 3 things that increase the risk of congenital syphilis infection. The first is early stage syphilis. The highest spirochete burden and the greatest risk of transmission occurs if syphilis is early stage, so primary or secondary syphilis. The second is maternal infection late in pregnancy, when there's too little time to treat before delivery, or in other places where they're not doing 3rd trimester testing, where moms may not even be tested before delivery. And then the last thing is failure to test and treat, which is your one modifiable risk factor. As I said when I started this section, 88% of cases involve the missed opportunity to test or treat adequately. And that's really where we wanted to intervene. So to understand congenital syphilis, you need to do two things. You need to first understand syphilis in the mother and then understand syphilis in the neonate. So first, we want to identify if syphilis occurred in the mother, determine if maternal treatment was adequate. Then we want to look for the presence of clinical lab or radiographic evidence of syphilis in the neonate and compare maternal and neonatal non-treponemal serologic titers. So let's meet Jen. Jen's a 34-year-old bisexual female pregnant with her first child. Her partner of 10 years is a 36-year-old bisexual man. They're in a committed open relationship and both have other same-sex partners. And she comes in for prenatal care at about 10 weeks gestation. Next, we have Eve, who's 29 and pregnant with her first child. The baby's father does not intend to be involved. She described him to me as a one-night stand and presents for prenatal care at about 12 weeks gestation. Finally, Alex, a 24-year-old female pregnant with her first child, pregnant with her high school sweetheart, and neither of them has ever had any other sexual partners. So which of these three people should be screened for syphilis? Hopefully, after all the talk from today, you recognize that it really should be all of them. In fact, the recommendation for pregnant patients is that first they should be screened at the first prenatal encounter, plus the third trimester and at delivery if high risk or an endemic area, or in New York State, New York City, or any other place where testing 3 times during pregnancy is recommended. One of the things that I always encourage providers to do is to not read this table and to actually screen for syphilis anytime you're screening for sexually transmitted infections. Unlike gonorrhea and chlamydia, we have continued to see total cases of syphilis rise. And the only way we'll reverse that is if we do a better job of screening for syphilis whenever we're screening for other sexually transmitted infections. So going back to our 3 patients, our first patient, the RPR was reactive with a titer of 1 to 1. Our second patient, the RPR titer was 1 to 8. And the third patient, RPR reactive with the RPR titer 1 to 1. So with our test results back, what else do we need to know to properly evaluate our patients and their future children? So first is identifying syphilis in the mother. It's important to remember that actually the RPR isn't that important if people have symptoms of primary or secondary syphilis. The RPR really helps us diagnose latent syphilis when people don't have symptoms. And to do that, we use the RPR as well as qualitative treponemal testing. And it's a lot easier to see on this algorithm here. So again, syphilis testing is most relevant for those without clear signs. Patients who have a chancre actually can have a negative RPR. So you shouldn't exclude syphilis in someone who has a clinical exam that looks like syphilis, even if testing is negative. So the traditional algorithm starts with the non-treponemal test, an RPR or a VDRL. If positive is confirmed with a treponemal test. And then a positive treponemal test is evidence of syphilis infection. But it actually doesn't distinguish between active or prior treated infection. To do that, you need to interpret the quantitative RPR that we'll do on the next slide. Conversely, the reverse screening algorithm starts with a direct treponemal test, like an EIA or CIA. It reflexes to a non-treponemal test, like the RPR or VDRL. And if the results don't match, goes to a second treponemal test to clarify the diagnosis. Again, if evidence of syphilis infection, if reactive and evidence of syphilis infection, it could be current infection or prior treated infection. And for that, we need to interpret the quantitative RPR. Yeah. If TPPA is negative, it really should be a false positive. I apologize, this box is wrong. In addition to serologic testing, there are other signs of congenital syphilis. Fetal infection may be suspected if there are characteristic non-specific findings on ultrasound exam after 20 weeks of gestation. Findings occur again after 20 weeks because that's when the fetal immune system matures enough to have this inflammatory response. Some of these non-specific findings that may be found on maternal ultrasound include hepatomegaly, placentomegaly, anemia, polyps, and ascites. Again, it's important to note that abnormal ultrasound is not diagnostic. There are other things that can cause these, and a normal ultrasound does not exclude fetal infection. So returning to our cases, looking at Alex's course, her labs are notable for an RPR that's reactive, with a titer of 1 to 1. However, her TPA test is negative. If you remember, Alex is the one who said she's only had one partner in her lifetime. They were high school sweethearts. And she was convinced that this had to be a false positive, and she was right. Her RPR was positive, but her confirmatory testing was negative, making this likely a false positive. False positives are more common in pregnancy. A positive low titer non-treponemal screening test can be considered a transient false positive due to pregnancy if the confirmatory test is negative, the patient is asymptomatic, and they're not particularly vulnerable to infection. For example, in this case, she'd only had one lifetime partner. Repeating the RPR right now is unlikely to be helpful, as these can remain positive for up to 6 months. But we do recommend that all women with a false positive in pregnancy get follow-up sometime after delivery. However, for Alex, this means that her baby does not need any further workup because she did not have syphilis during pregnancy. And so in Alex's case, we did not identify syphilis in the mother. However, what if the mom had had syphilis? In that case, we need to know whether maternal treatment was adequate. Determining whether maternal treatment is adequate requires us to recognize the symptoms at the time of diagnosis, history of prior testing, number and timing of doses given, and the chances of reinfection. So if we go back to one of our patients, Eve, her labs were notable for a positive RPR with a titer of 1 to 8 at the end of her first trimester, and confirmatory testing did return positive. We took a detailed history and found that she had never had any symptoms, but had also never been tested before. So what stage is she, and what treatment does she need? So before we get to treatment, understanding adequate treatment requires us to understand the proper staging of syphilis. And this is important as staging directly relates to how we treat, as well as how much treatment our patients require. So this diagram from the New York City STD Prevention Training Center and New York City Department of Health Syphilis monograph, I think highlights the stages of syphilis really well. It starts with the incubation period, where after a recent exposure, you may not test positive and have no symptoms for up to 90 days. Therefore, pregnant patients who are sexual contacts of partners with known or suspected syphilis should be presumptively treated as opposed to waiting for a test and treat strategy. After incubation is primary syphilis, and we think of primary syphilis as defined by local symptoms. This is traditionally the painless chancre that we think of as the site of inoculation. Can actually be one or more ulcers at the site of inoculation. Because they're painless, they may go unnoticed. It's important to know that people may not see the chancre, especially if it's in the throat, in the vagina, in the rectum. And so just because people don't remember seeing the chancre doesn't mean it's not syphilis. It's often associated with regional or bilateral lymphadenopathy, occurs 10 to 90 days after infection, is highly infectious, and resolves in 1 to 6 weeks. One thing I do want to highlight is we are seeing more atypical syphilis presentations, where instead of single painless ulcers, we're seeing multiple atypical or painful lesions at the site of infection, particularly in the rectum. And so, as Osler said, to know syphilis is to know medicine. Syphilis really is the great imitator. And just because people have multiple painful lesions, we shouldn't exclude syphilis in the differential. Secondary syphilis is disseminated syphilis. These are what we typically think of as the rash on the palms and soles, but actually it can be much more than that. It's disseminated, and so while dermatologic manifestations are the most common, you can also have painless generalized adenopathy, low-grade fevers, fatigue. It usually is 4 to 8 weeks after infection, resolves in 6 weeks, and is highly infectious. You can also have other systemic symptoms like GI effects, renal, musculoskeletal, neurologic, and ocular otic that we'll talk about in a little bit. Latent syphilis is by definition asymptomatic. Early latent is when it's possible to document non-reactive syphilis serology within the past year, or a history of symptoms of early syphilis within the past year. Otherwise, the disease is considered late latent or syphilis of unknown duration. And these designations are really important because they determine what is adequate treatment for syphilis. So just as a reminder, early latent is less than 1 year, late latent is greater than 1 year, and then latent syphilis of unknown duration is no prior testing or no access to prior testing. And we lump that together with late latent when it comes to treatment. So we treat based on the stage. For incubation, primary, secondary, and early latent, our primary treatment has been benzodiazepine penicillin G or BPG once. but due to the ongoing shortage, we're more and more frequently using the alternative treatment regimen of doxycycline 100 milligrams twice daily for 14 days. For late latent syphilis of unknown duration and tertiary non-neuro, traditionally it's been BPG weekly for 3 weeks. However, again, due to the ongoing shortage, we're using doxycycline 100 milligrams twice daily for 28 days very commonly. And for patients presenting with neuroocular and otic syphilis, which can actually occur at any stage of syphilis, it's IV penicillin. There is not currently an IM alternative on the market. However, we're talking today about syphilis in pregnancy, and treating syphilis in pregnancy means we don't have an alternative regimen. The recommendations are that pregnant patients who have a history of penicillin allergy should be desensitized and treated with penicillin. One other additional caveat among people with syphilis in pregnancy, there's this line in the 2021 STI treatment guidelines. Certain evidence indicates that additional therapy is beneficial for pregnant women to prevent congenital syphilis. For women who have primary, secondary, or early latent syphilis, a second dose of benzene penicillin G can be administered 1 week after the initial dose. There is not a lot of clinical evidence for this. I've been doing it less and less with the ongoing shortage due to the desire to conserve BPG. This is based on theoretical pharmacokinetic concerns, and hopefully we'll get more data about in the future to better understand how meaningful this is. In terms of treating syphilis in pregnancy, we want to be really aggressive. Clinical experience suggests that 10 to 14 days between doses of BPG for latent syphilis might be acceptable, except in pregnant or an interval of 7 to 9 days is preferred. So while we say 10 to 14 days may be acceptable in non-pregnant persons, for pregnant persons, we say that missed doses greater than 9 days between doses are not acceptable, and that patients who miss a dose of therapy should repeat the full course of therapy, meaning that they should restart if they need the 3-dose therapy. So in order to diagnose and treat syphilis in pregnancy, you really need to know the staging. You need to know the symptoms at the time of diagnosis, history of prior testing. You want treatment based on staging. You want a number and the timing of doses given, and the chances of reinfection, including partner treatment. In terms of managing syphilis during BPG shortages, I think what Preeti told us earlier was really fantastic. We don't expect there to be BPG back here until Q4 2027 at the earliest. So we really need to make an effort to prevent new infections through partner services, repeat testing, and time. We want to make sure that we stage accurately. We just talked about how treatment and staging interact with each other. Many times I see people giving 3 doses when one would have been adequate. So we really want to make the extra effort to stage accurately to try to save 2 doses whenever we can. And again, using doxycycline for non-pregnant adults who can tolerate it really removes their demand entirely so that we're able to conserve BPG for pregnant patients and infants. So going back to our patient, Eve came in with a titer of 1 to 8, was TPA positive, had no symptoms that she knew about, and had never been tested for syphilis previously. She was diagnosed with latent syphilis of unknown duration and received BPG weekly for 3 weeks. Next up is Jen. So Jen was RPR reactive with a titer of 1 to 1, and her TPA was positive. However, we were able to obtain outside records, and it turns out she was treated 1 year ago with a titer of 1 to 64 with 3 shots of penicillin G, each 7 days apart. And her partner had received treatment at that time as well. And so actually, when looking at this, does this mean that Jen does need treatment again, or is she adequately treated? For that, we really need to understand how to interpret titers. So non-treponemal tests like the RPR are what we use to follow treatment response and look for evidence of reinfection. And this is true both in the traditional or reverse algorithm. While RPRs occur at different time points in those algorithms, the RPR is what we use to understand about prior infection versus reinfection. And quantitative testing just involves the serial dilution of specimens to determine how much antibody is present. The higher numbers, the more antibody is present. A 2 dilution change or a 4-fold increase or decrease in titers is considered clinically significant. A 1 dilution change or a 2-fold increase or decrease in titers is not. So what we're looking for is a 2 dilution change or a 4-fold increase or decrease in titers. So looking at Jen's course, she was 1 to 64, and now she's 1 to 1. That's a greater than 4-fold decrease. And so it does not appear that she has reinfection and does not need further treatment at this time. And we can conserve that dose of BPG. However, Jen came back at 32 weeks. She was asymptomatic, however, repeat labs were notable for an RPR that was reactive with a titer of 1 to 16 now. So that's obviously a greater than fourfold increase from 1 to 1. And so she was treated with BPG 2.4 million units IM times 1 for early latent syphilis. So now that we understand how to diagnose syphilis in the mother, we have to think about the children as well. And the Red Book says that no newborn infant should be discharged from the hospital without determination of the mother's serologic status for syphilis. And so after diagnosing syphilis in the mother, the next step is to diagnose it in the neonate. To do this, we want to look for the presence of clinical, lab, and radiographic evidence of syphilis in the neonate. In terms of clinical evidence, things like hepatomegaly in the infant, syphilic rhinitis, lymphadenopathy, pneumonia, pseudoparalysis, edema, a rash, and osteochondritis are all clinical signs and symptoms. And there's a really nice New England Journal review article from a couple years from 2024 that has this nice image that kind of goes through all the different potential findings consistent with a clinical diagnosis of congenital syphilis. We also have photos, some of these older photos that demonstrate what the syphilitic rhinitis or snuffles look like, the enlarged liver, bony changes, as well as the typical rash of congenital syphilis. And then in the New England Journal paper, as well as in a recent clinical infectious diseases state-of-the-art review, we have additional more recent images of what the rash looks like, syphilitic rhinitis, and then this rash again, really demonstrating that what we're looking for most commonly is a rash, but there are a lot of other clinical signs and symptoms. From a lab standpoint, we can look for lab evidence like anemia, thrombocytopenia, leukopenia, leukocytosis, and abnormal CSF. Again, some of these are not necessarily diagnostic for congenital syphilis, but can certainly point us in the right direction. And finally, radiographic evidence, which it does not necessarily happen at birth. It's usually a couple of weeks later before you can see it. But things like periostitis, metaphyseal serration, and demineralization and destruction of the upper medial tibia are all some of the radiographic evidence of early congenital syphilis. All right. There you go. The last step is comparing maternal and neonatal non-treponemal serologic titers. So again, we're looking for whether the infant titer is fourfold or more higher than mom's titer or the same. So just like we did for mom comparing to herself to see about reinfection, we're comparing to mom to look for new infection for infection in the neonate as well. So our first mom was treated with penicillin IM times 1 at 32 weeks. The baby was born at 34 weeks via C-section due to fetal distress, and the exam was normal. Eve was treated with penicillin IM times 3 at 12 weeks, retested at 28 weeks in RPR titer 1 to 1. The baby was born at 38 weeks via normal spontaneous vaginal delivery, and exam was normal. And Alex was not treated as she had a positive RPR and negative TPA. She was diagnosed with a false positive RPR, and her baby was born at 40 weeks via C-section for failure to progress with a normal exam. In terms of putting this all together for the baby, we need to be able to first identify whether mom had infection and then whether or not we need to do anything about it. I'm going to go through this relatively quickly in the interest of time, but I think it is important. Proven or highly probable is very easy. A physical exam consistent with congenital syphilis, a titer in the baby that's fourfold or greater than the maternal titer, or evidence of direct detection of treponema pallidum either through dark field microscopy or from a PCR done on either the syphilitic rhinitis or the skin itself. Those babies get a full, complete workup, and they also, including a lumbar puncture, and they also get IV treatment for a total of 10 days. That's a pretty easy group. Possible is a little bit more complicated. These babies have a normal physical exam, serum quantitative non-treponemal titer less than fourfold the maternal titer, so none of the proven or probable criteria. But either mom was not treated, mom was inadequately treated, including with a non-penicillin G regimen, or didn't complete all of the doses. Mother has no documentation of having treatment, or mom received treatment less than 30 days before delivery. In that case, we should do a CSF analysis, so a lumbar puncture, CBC, and long bone radiographs, which are optional if we're going to treat anyway for 10 days. The treatment is a possible 10-day IV treatment or single dose IM, And everyone at this point always asks, well, why can't I just do the single dose IM every time? And really, the single dose treatment is if the evaluation is completely normal. If the workup is abnormal, uninterpretable, CSF is contaminated with blood, workup not performed, or uncertain follow up, then really they should get 10 days of treatment. If everything is totally normal, you can do single dose therapy. And so Jen's baby was actually born at 34 weeks gestation via C-section, required stimulation with APGARs of 7 and 9. The baby was appropriate for gestational age, and the RPR titer is 1 to 2. Mom's titer is 1 to 8 at birth. However, the baby received 10 days of IV penicillin therapy after a 48-hour rule out of AMP and Jen because Jen was treated at 32 weeks, and so it was less than 4 weeks or less than 30 days before delivery, and so required treatment. The less likely criteria is a very common one that we see, normal exam, baby titer less than fourfold maternal titer. Mom was treated appropriately during pregnancy. Treatment was greater than 30 days before delivery, and mom has no evidence of reinfection or relapse. So everything was done correctly. Mom was diagnosed with syphilis during pregnancy and got appropriate treatment. In this case, no evaluation is recommended, and they can either give single dose BPG or no treatment with close follow up. And this is what happened to Eve's baby. Was born at 38 weeks gestation, required minimal stimulation. Baby was appropriate for gestational age. The RPR was positive with a titer of 1 to 8, and the treating pediatrician made the decision to give her the one dose of BPG, but didn't do any additional workup or evaluation. The last category, the unlikely criteria, these ones don't have any evidence of congenital syphilis, and mom actually didn't have syphilis during pregnancy. Mom was diagnosed and treated adequately before pregnancy, and mom's titer remained low and stable during pregnancy and delivery. This does come up a lot, though, because people will have a persistently positive titer even after treatment. Again, if treatment was before pregnancy and was appropriate and the titer came down, no evaluation is recommended and no treatment is recommended. In terms of follow-up, for neonates with a positive non-treponemal test, we recommend repeating every 3 months. In patients not treated at birth, they should be non-reactive by 6 months. If reactive, we need to think about retreatment. We need to think about treatment. In patients treated at birth, they should be non-reactive by 12 months. And if they're still reactive, we want to think about an LP and 10-day course of IV penicillin. For neonates with a negative non-treponemal test and the mom is positive at birth, we should repeat the non-treponemal test at 3 months to rule out the incubation period. If the baby did get a full 10-day course of IV penicillin, there is no recommendation, and I generally recommend repeating the non-treponemal test at a regular pediatrician visit. Lastly, neonates with abnormal CSF, there's a lot of discussion about whether they need additional workup. They really don't need repeat lumbar punctures unless they exhibit persistent non-treponemal serologic test titers at age 6 to 12 months. Persistent non-treponemal titers and CSF abnormalities should be managed in consultation with an ID expert. And that is everything I've got for you guys today. I just want to highlight a couple of additional training opportunities, the National STD curriculum, some on-demand trainings we offer through the PTC, and some help with interpreting syphilis serology. And with that, I will stop and give us 10 minutes for questions.
Thank you so much, Dr. Zucker, and thank you, Dr. Patella, as well, for your presentation. Just a reminder to everyone on the line, if you have questions for our speakers, please drop those in the Q&A box located at the bottom of the Zoom screen. We will be sharing slides as well later today, as well as we are recording today's webinar, and that will eventually be shared as well. And any of the resources that either of our presenters mentioned, we'll be sure to share those via email also. All right, in the Q&A box, so we do have a question that was covered, but just want to reiterate it, asking about the use of doxypep during pregnancy.
Great question. We generally do not recommend doxycycline during pregnancy. I think there's some controversy and discussion about that these days, but in general, we do not recommend doxycycline during pregnancy at all, which is why we don't recommend it as an alternative treatment option for pregnant people. And so right now, we do not have a prophylactic or preventative option for STIs during pregnancy.
Thank you. Other questions from folks? So we had received a question asking, do we need to repeat RPRs in infants if they were non-reactive at birth? And if they are high risk, do they need to receive the 10 days of IV penicillin months after treatment?
So when you say high risk, that's a little bit of I don't know exactly what they mean, but we have the different categories here. So depending on what category they fall into, if they're in the possible category and you're unable to get a complete workup, then they should get the 10 days of IV penicillin. If they're in the less likely category, then they only need a single dose. In patients who get the full 10 days, there's actually no recommendation made about repeating the RPR after birth if they were negative at birth. However, I generally recommend that it's a good idea, but to do it with a pediatrician visit. They don't necessarily need to do it um, just in general or have a special visit just to do it. Sorry, is what I'm trying to say.
Thank you. I'm also going to drop in the chat a hybrid event that is happening tomorrow in New York City to bring awareness to syphilis during pregnancy. So please take a look at that in the chat if you are in the area and interested. Any other questions from folks? So as people are putting in questions, I know one question we're often asked is, when we look at the data that you both shared about how are these cases missed? And one area that we often see is that for pregnant patients, particularly that they may not be engaged in prenatal care, may not get any testing prior to delivery. So just wondering in those cases, what kinds of recommendations you have for providers in thinking about how to care for patients who come in maybe late in pregnancy or during delivery and haven't previously been engaged in care, as far as thinking about syphilis particularly.
Yeah, I mean, the big thing is making sure you test them at that point. The problem from a numbers standpoint is if they come in at the time of delivery and then are diagnosed, you're already within that 30-day window. And so while we treat them and we ensure that the baby gets full treatment as well to prevent the sort of long-term potential harm of congenital syphilis, they'll still be counted as a case. At that point, it's a little bit too late to intervene. So it becomes sort of a harm reduction situation, making sure mom is treated and make sure your baby is treated as early as possible.
Thank you. Well, right now we have no other questions. If folks do think of questions and want to send them in via email, we can get those answered for you as well. But at this point, I just would love to thank our two speakers, Dr. Pathella and Dr. Zucker. Thank you so much for being here with us and for your presentations. Thank you to everybody for joining us. As mentioned, we will share the CE information later today via email, along with slides and resources. So stay tuned for those. And again, just thank you so much for your time. One question did just come in, so
Yeah.
sorry as I'm wrapping up here. So there's a question asking about a female patient or a female baby, it looks like, who was born with syphilis, treated preventively at that time. Titer's been stable. When this person later became pregnant, her titer rose fourfold always. Her partner is always negative. Should you treat?
I would say yes. If her titer increased fourfold, um, I would probably treat. If it's early in pregnancy and you wanted to try to repeat it in 2 weeks because you thought it was a false positive, that wouldn't be crazy, but I wouldn't wait too long during pregnancy to retreat.
Thank you. I'm also just going to drop in the chat the STD Clinical Consultation Network. This is a website where you can submit any clinical consult, any questions you have about caring for patients with STIs. You send those to us, and Dr. Zucker and other clinical folks on our team will respond to those. So if you have specific clinical questions, feel free to send those there. All right. I'll continue to wrap this up, but thank you again, everybody. Really appreciate your time. Thanks for being with us. We'll follow up via email and we'll share resources as well. But thank you so much. I hope everyone has a great rest of their day.
Thanks, everybody.
Thank you.